Welcome to our deep dive into, the fascinating and honestly often harrowing world of acute neurocognitive emergencies.
Yeah, it's a massive topic.
It really is. Today, we are focusing on Chapter 10.2 on delirium, and this is from Kaplan and Sadok's comprehensive textbook of psychiatry.
Right, the definitive text.
Exactly. And our mission for you, the listener, whether you are a psychiatry registrar, a clinician on the wards, or just a really motivated student of medicine, is to move far, far beyond just, rote memorization.
Absolutely. Because memorizing a list of symptoms doesn't help you when you're actually standing in front of a patient at 3 in the morning.
Spot on. So we are here to build robust mental models to clarify the underlying neurobiological mechanisms and really strengthen your clinical reasoning. We want you to understand exactly how psychiatrists think about this specific life-threatening medical emergency.
And to set the foundation for that mission, we really need to anchor ourselves in the core philosophy of psychiatry itself, right?
I agree. Yeah. Where do we start with that?
Well, psychiatry is fundamentally the study of how the brain, the mind, and human experience all interact dynamically. It's the observation of that complex, highly integrated process. And crucially, it's the study of how that exact process can suddenly and catastrophically go wrong.
Yeah, and I think the best way to conceptualize what it means when that process goes wrong is through a structural metaphor.
Well, I love a metaphor. Let's hear it.
Right. So let's step away from the textbook for just a second and build a mental model. Imagine an investigator, let's call him Medlock Holmes.
Medlock Holmes, nice.
Right. So he arrives in this magnificent, highly complex and bustling city, and this city represents the human brain.
Okay, I'm with you.
Under normal circumstances, it functions with remarkable precision. Traffic flows smoothly along the motorways, which, represents our neural pathways. Chemical messages are delivered accurately by couriers. Citizens recognize one another on the streets, meaning memory and perception are totally intact.
Yeah, and the market's open on time, which is dictated by a perfect circadian rhythm.
Exactly. The entire system depends upon a continuous, reliable supply of metabolic energy to maintain this sophisticated integration.
And that integration is the absolute hallmark of a healthy, awake state. The city is responsive, it's actively filtering out irrelevant noise, and it's prioritizing essential operations.
But then, one morning, something changes. Medlock Holmes notices the city's power grid is beginning to fluctuate.
So not a complete blackout.
Right, not a blackout, but a profound instability. Lights flicker unpredictably. The communication networks fail intermittently, which causes the traffic signals to fall out of sync. Roads that were easily navigable suddenly become chaotic.
Wow, yeah, so the citizens are wandering aimlessly, completely disoriented.
Yes, and some are terrified, screaming and running through the streets in agitation, while others are just, sitting on the curbs, lethargic, withdrawn, and barely responsive to the chaos around them.
And you know what is most striking to the investigator in this scenario? Is what he does not find.
What's that?
Well, when Holmes inspects the buildings, the actual physical structure of the city is completely intact. The skyscrapers haven't collapsed, the roads haven't been physically torn up.
Oh, I see.
Yeah, if you were to take a satellite photograph, which is basically the equivalent of a structural MRI scan, the city would look entirely normal.
Which highlights a fundamental distinction we really need to make early on. This is not the slow, creeping physical decay of a crumbling infrastructure.
No, exactly. Because that slow structural decay represents dementia, where the neurons themselves are degenerating over years.
Right. What Medlock Holmes is observing is an acute, terrifying crisis of function. The machinery remains largely intact, but the brain's ability to maintain a stable, coherent operation has completely failed.
And this unstable power supply, that is delirium.
It is. And the defining characteristic that Holmes notes is the rapid onset. Yesterday the city was functioning. Today it is profoundly altered.
And that rapid onset is the absolute pivot point of clinical diagnosis. We are dealing with an etiologically nonspecific organic cerebral syndrome.
That is a mouthful. We should probably break that terminology down.
We definitely should, because it dictates the entire clinical approach. So, etiologically nonspecific implies that delirium is not a single disease.
Right, you can't catch delirium in the way you catch a virus.
Precisely. It is instead a final common pathway of brain dysfunction. It's a shared syndrome triggered by a vast array of underlying insults. Anything from sepsis to organ failure to pharmacological toxicity.
Yeah.
And is characterized by an acute, rapidly developing, and crucially fluctuating decline in awareness, cognition, and attention.
The etymology of the word itself perfectly captures this clinical reality. The term originates from the Latin verb deliro, which translates literally to go out of the furrow or veer off the track.
Oh, an agricultural term.
Yeah, exactly. You can picture a farmer plowing a straight line through a field, and suddenly the plow just jerks wildly off course.
Yeah.
The patient was on a functional track, maintaining their cognitive equilibrium, and an acute insult has caused them to entirely derail.
That's a brilliant visual. And when we examine the epidemiology of this derailment, the statistics are just staggering. They really underscore why every single clinician must master this topic.
Let's get into the numbers because they surprised me.
Well, if you assess community-dwelling older adults, the prevalence is relatively low, less than 2%.
Because the home environment is stable, predictable, and sensory-rich, right?
Exactly. However, the moment an older adult crosses the threshold of a hospital, the landscape shifts dramatically. Upon general hospital admission, the prevalence skyrockets to between 14 and 24%.
Wow. And those numbers escalate even further depending on the severity of the medical intervention, don't they?
Oh, absolutely. In post-operative settings, particularly following orthopedic surgeries like hip replacements or in the intensive care unit, the incidence can reach upwards of 56%.
Wait, 56%. So more than half of the patients in an ICU may be experiencing this profound cerebral failure.
Yes. Yet, despite its ubiquity, there is a chilling statistic that every medical student needs to internalize. Between 40 and 60% of delirium cases are misdiagnosed or completely missed by healthcare professionals.
That is genuinely terrifying. I mean, how are we missing something that affects more than half of ICU patients?
Well, the clinical failure to recognize delirium stems largely from a misunderstanding of how the syndrome actually develops. To spot the dysfunction, clinicians really have to evaluate the patient through the lens of the multifactorial model.
Right.
This model conceptualizes delirium as an intersection between a patient's baseline vulnerability and a precipitating physiological insult.
Let's make this concrete. I think an original analogy might help here. Let's call it the full cup of vulnerability.
I like the sound of that. Walk me through it.
So, rather than viewing delirium as a simple cause and effect, we should view this through the concept of allostatic load and diminished cognitive reserve. Imagine the brain's homeostatic mechanisms as a cup, right? A complex buffer system designed to absorb physiological stress.
Okay, so a healthy 25-year-old brain would be an empty cup.
Exactly. They possess an immense cognitive reserve. The buffer is vast. To exhaust that reserve and make the cup overflow, precipitating delirium in a young, healthy person, you have to introduce a catastrophic insult, a massive pour of water.
Right, like severe traumatic brain injury, overwhelming systemic sepsis, or profound multi-drug intoxication.
Spot on. The insult must be massive to overcome that robust physiological infrastructure.
Conversely, as we age, or as neurodegenerative processes begin to alter our brain architecture, that cognitive reserve diminishes. The cup is already starting to fill up.
Exactly. So if you are evaluating an 85-year-old patient with pre-existing dementia, their baseline vulnerability is already at a critical threshold. Their cup is basically 99% full.
Their neurochemical pathways are fragile, their blood-brain barrier might be more permeable, they're balanced on a knife edge.
Therefore, it does not require a catastrophic insult to push them over the edge. A relatively minor physiological stressor, just one tiny drop of water, like a mild urinary tract infection, a slight sodium imbalance, or even a standard dose of a new sedative is completely sufficient to overwhelm their depleted reserve.
That minor insult triggers the sudden onset of delirium. It spills over.
Yeah, and this is exactly why advanced age and pre-existing dementia are identified as the absolute most significant predisposing factors.
Absolutely. And other critical predisposing vulnerabilities include a prior history of delirium, which suggests, an enduring fragility in those neural networks.
Right, the system has broken before.
Exactly. We also have to consider functional impairments and severe sensory deficits, like advanced macular degeneration or profound hearing loss.
Because you're removing their anchor to reality.
Spot on. When you remove a patient's sensory anchors, the brain really struggles to accurately construct reality, leaving it highly susceptible to confusion. Furthermore, baseline depression and a history of chronic alcohol abuse significantly erode that cognitive reserve, basically priming the central nervous system for an acute failure.
Okay, so once that baseline vulnerability, the full cup, is established, we have to look for the precipitating insults, the actual triggers. And honestly, in a hospital ward, the environment itself is often highly iatrogenic.
It really is. We subject patients to polypharmacy, suddenly introducing 3 or 4 new medications that interact unpredictably.
We utilize physical restraints, which induce immense psychological and physiological stress.
We insert indwelling bladder catheters, introducing both a source of infection and this constant noxious stimulus.
Yeah, and you add to that the factors of malnutrition, unmanaged pain, and the relentless disruption of the sleep-wake cycle on a noisy ward, and you just have the perfect recipe for neurocognitive collapse.
It's a miracle it doesn't happen more often, really. But if we accept that these insults trigger the collapse, the next logical step in our reasoning is to understand the mechanism.
Right. If delirium is just the symptom, the warning light flashing on the dashboard, what is actually happening under the hood? How did we figure out the mechanism of this power failure?
To comprehend the pathophysiology, it is highly instructive to trace the historical progression of our understanding, because physicians have been documenting this specific presentation for millennia.
The continuity of medical observation here is just extraordinary. I mean, the earliest known clinical description resides in the Hippocratic corpus, specifically within the Book of Epidemics, which dates back 2,400 years.
Wow, 2.5 millennia.
Yeah. Hippocrates documented the case of a man named Erasinus. The clinical notes detail that Erasinus presented with a high fever, followed by severe nighttime agitation, disjointed speech, and incoherence.
Classic hyperactive presentation.
Exactly. And what is remarkable is that Hippocrates specifically noted that Erasinus would appear rational and coherent the following morning, only to plunge back into furious madness before noon.
That fluctuation.
Yeah, the fluctuation. Eventually, the patient succumbed to the illness, unfortunately.
Hippocrates captured the absolute essence of the syndrome right there. The acute onset, the underlying physiological illness, the fluctuating level of awareness, and the high mortality risk.
Which is incredible because that fluctuation remains a core diagnostic criterion today. And building upon this, in the 1st century AD, Arates of Cappadocia made a vital phenomenological distinction.
Right, he observed that these acute mental derangements did not present uniformly.
He divided them into 2 categories. Phrenitis, denoting a hyperactive, frenzied state often accompanied by fever, and lethargicis, describing a profound, hypoactive sluggishness.
He essentially mapped out the hyperactive frantic district and the hypoactive quiet district of our metaphorical city.
Exactly. That distinction was a massive leap in clinical observation. However, for centuries afterward, the underlying mechanism basically remained shrouded in the broader, imprecise concept of general madness.
Yeah, it wasn't until 1583 that Philip Barrow articulated that this was not madness in the psychiatric sense, but a derangement of internal senses, specifically imagination, cognition, and memory.
Right, making it a cognitive issue.
Yes, and by the late 17th century, Thomas Willis formalized the concept that delirium was a cohesive syndrome, an overarching pattern of symptoms arising from systemic illness rather than a primary disease of the mind.
An intriguing philosophical leap occurred later, in the late 18th century. Erasmus Darwin and the anatomist John Hunter proposed comparing delirium to a dream state.
A waking dream.
Yeah, they characterized it as an interruption of voluntary power and a cessation of waking consciousness. They hypothesized that the delirious brain loses its tether to external reality, dropping into a state akin to dreaming, yet the patient remains physically awake.
And that waking dream concept is phenomenologically very accurate when you observe a patient interacting with visual hallucinations. But, it lacked physiological proof.
So when did we actually prove it? The definitive scientific breakthrough? The moment we finally proved the underlying mechanism of the power failure? When was that?
It didn't arrive until the mid-20th century. This was driven by the pioneering work of George Engel and John Romano.
Right, the energy crisis breakthrough. What did they do?
Well, Engel and Romano revolutionized our understanding by applying electroencephalography, or EEGs, to delirious patients. They weren't just observing behavior anymore, they were directly measuring the electrical activity of the cerebral cortex.
And what did they find?
What they discovered fundamentally redefined delirium. They demonstrated that the syndrome was inextricably linked to a global reduction in the metabolic activity of the brain.
Let's delve deeply into the physiology of this EEG finding because it really represents the smoking gun of delirium, doesn't it?
It really does. When you record an EEG on a healthy, alert individual, the tracing is characterized by fast, high-frequency, low-amplitude waves, primarily alpha and beta activity.
Which reflects what, exactly?
It reflects millions of cortical pyramidal neurons firing asynchronously, rapidly processing disparate streams of sensory and cognitive information. It is the signature of a highly active, metabolically demanding, and focused brain.
Okay, so that's the healthy city humming along, but what did they see in delirium?
When Engel and Romano examined patients in delirium, those rapid, complex waveforms vanished. They were replaced by diffuse, slow-wave activity, typically in the theta or delta frequency ranges, alongside a general low-voltage background.
And the slow wave dominance means the neurons are basically firing sluggishly and synchronously, right?
Exactly. They are no longer processing complex, independent data streams. This electrical slowing is the direct electrophysiological manifestation of a global metabolic energy crisis.
The power grid is failing.
Yes. The brain simply lacks the metabolic fuel or the neurochemical signaling capacity to maintain high-level cortical processing.
And the profound insight from their research was the discovery of a direct proportional correlation, wasn't it?
Spot on. The more prominent the slow wave activity on the EEG, the more severe the patient's cognitive and attentional deficits appeared clinically.
Wow. And this was across all types of delirium.
Yes, this metabolic slowing was universal across the different subtypes. Whether a patient was thrashing aggressively in a hyperactive state or lying perfectly still in a hypoactive stupor, their cerebral cortex was starved of energy. The hardware was failing.
So this definitively established that delirium is a measurable physiological crisis, not just, a psychological break from reality. The brain is failing to integrate information.
Exactly. Which leads us directly to the neurochemical mechanisms that precipitate this energy failure, frequently conceptualized as the toxidrome mechanism.
Right, because the communication infrastructure of our city relies on specific chemical messengers. So when the power grid becomes unstable, it's frequently because systemic toxins or exogenous medications are disrupting these critical neurotransmitters.
And the textbook emphasizes that the most common and consequential neurochemical disruption involves the cholinergic system, specifically an anticholinergic burden.
Let's unpack that. Acetylcholine is key here, right?
It is the linchpin. Acetylcholine is the key neurotransmitter for the reticular activating system and the thalamocortical loops. It is absolutely vital for maintaining arousal, directing attention, and encoding new memories.
But so many medications have anticholinergic properties. We aren't just talking about obvious agents like tricyclic antidepressants or first-generation antihistamines.
No, not at all. We also have to consider sedative hypnotics, opioid analgesics, corticosteroids, and even some cardiovascular drugs.
So when you administer a cocktail of these medications to an older patient, the cumulative anticholinergic burden basically blocks the muscarinic receptors in the brain.
You are essentially severing the communication lines that allow the prefrontal cortex to maintain focus.
And simultaneously, delirium often involves a surge in dopaminergic activity and a dysregulation of gamma-aminobutyric acid, or GABA, right?
Exactly. This neurochemical chaos-reduced acetylcholine, combined with excess dopamine, creates a state where the brain simply cannot filter sensory input, cannot maintain a train of thought, and cannot differentiate reality from internally generated imagery.
So the power is fluctuating, the brain's metabolism is slowing down, the chemicals are a mess. What does that actually look like on the streets of our metaphorical city? What are the clinical manifestations?
Well, the central defining feature, the very first cognitive casualty of delirium, is the impairment of attention.
And it is critical to differentiate attention from other cognitive domains, like memory or executive function, isn't it?
It is, because attention is the foundational pillar of conscious experience. It's the ability of the central communication network to highlight relevant stimuli while actively suppressing irrelevant noise. Without attention, the entire cognitive edifice crumbles.
I mean, consider the implications of profound inattention. A patient can't encode a new memory if their brain cannot sustain focus on the present moment.
Right. They cannot solve a problem or follow a two-step command because their working memory is constantly wiped clean by distraction.
They cannot accurately perceive the room around them because their brain is unable to selectively filter out, say, the hum of the ventilator or the shadows cast by the blinds.
Exactly. And the clinical presentation of this inattention is profound distractibility. If you attempt to interview a delirious patient, they just cannot maintain a coherent narrative.
They might answer your first question, but midway through the second, their gaze wanders, they mumble about something occurring in the hallway, or they simply drift off into silence.
Their cognitive spotlight is broken. It swings wildly or flickers out completely.
Furthermore, this cognitive failure operates on a distinct temporal rhythm, which is heavily influenced by circadian dynamics. Clinicians frequently observe a phenomenon known as sundowning.
Ah, yes, sundowning. The symptoms of delirium characteristically exacerbate in the late afternoon and evening.
It's a fascinating intersection of physiology and environment, really.
Yeah.
As the day progresses, the metabolically compromised brain becomes increasingly fatigued.
And simultaneously, as the sun sets and the hospital ward dims, ambient sensory input decreases.
Right. And the brain, which is already struggling to differentiate reality from hallucination, relies heavily on clear environmental cues. Bright lights, distinct sounds, familiar faces to anchor itself.
So when you remove those sensory anchors in the twilight, the confusion amplifies exponentially. The backup generators of our metaphorical city simply run out of fuel.
This fluctuating confusion manifests in three distinct clinical subtypes, the districts of delirium. Accurately categorizing a patient into one of these districts is absolutely essential for management.
Yes, the first is the hyperactive subtype.
The frantic district.
Exactly. It is impossible to ignore. The patient is in a state of sympathetic nervous system overdrive. They exhibit severe psychomotor agitation, profound mood lability swinging from terror to rage, and overt psychosis.
These are the patients actively pulling out their intravenous lines, attempting to climb over the bed rails, and shouting at unseen figures.
Spot on. This presentation is frequently driven by severe anticholinergic toxicity or acute drug withdrawal states, such as alcohol withdrawal.
Now, because hyperactive delirium is disruptive, it rapidly draws medical attention. But the greater clinical danger lies in the second category, the hypoactive subtype.
Yes, the quiet district. This is characterized by profound sluggishness, lethargy, apathy, and psychomotor retardation.
Let me push back a bit here, though. Isn't this just a tired patient? It's incredibly easy for a clinician or a nurse at the end of a long shift to look at a withdrawn, lethargic 80-year-old patient who just underwent major surgery and conclude that they are simply resting. I mean, it seems physiologically appropriate for them to be exhausted.
It does, but that is a critical error. You are failing to distinguish between normal sleep and pathological stupor.
What's the crucial difference?
A normally sleeping, fatigued patient possesses an intact reticular activating system. If you apply a stimulus, saying their name loudly or gently shaking their shoulder, they will rapidly arouse to a state of clear, lucid consciousness. They will orient themselves immediately.
Okay, and the hypoactive delirious patient?
They require strong, persistent, and often noxious stimuli to arouse. And crucially, when they do open their eyes, the arousal is incomplete. Their consciousness remains clouded.
They stare blankly, fail to track the conversation.
Exactly. And the moment you cease the stimulation, they slip rapidly back into a stuporous state.
That is such a vital clinical pearl, and this is the most common presentation in the geriatric population, isn't it?
It is. And it is the primary reason the misdiagnosis rate hovers around 60%. Hypoactive delirium is a silent killer. The patient is quiet and compliant, so nobody initiates a medical workup, while the underlying sepsis or renal failure that is causing the brain to shut down continues to progress completely unchecked.
Terrifying. Now, there is a third category, mixed delirium, which is arguably the most complex.
Yeah, here the patient's presentation fluctuates unpredictably between the hyperactive and hypoactive poles.
They may be combative and hallucinating in the morning, only to become profoundly unarousable by the afternoon.
And this unpredictable cycling is the most prevalent pattern observed in critically ill patients, particularly within the intensive care unit.
Now, regardless of the subtype, the perceptual disturbances experienced during delirium are often vivid and terrifying, right?
Very much so. We are looking at a high prevalence of hallucinations, predominantly visual hallucinations, occurring in at least 40% of all cases.
And the nature of these visual hallucinations loops back to Erasmus Darwin's concept of the waking dream. The textbook poignantly describes this phenomenon as sleep without muscle atonia.
That's a great way to describe it. During normal REM sleep, the brainstem actively paralyzes the body's skeletal muscles, a state called atonia, which prevents us from physically acting out our dreams.
But in the delirious state, the neurochemical gating fails.
Yes, the brain generates vivid, dreamlike, hallucinatory imagery, but the physical body remains fully mobile.
So the patient is quite literally trapped in a waking nightmare, moving through a world overlaid with terrifying projections.
And the delusions that accompany these hallucinations are rarely grandiose. They are overwhelmingly paranoid and persecutory. The patient genuinely believes the nursing staff are attempting to poison their intravenous fluids or that they have been kidnapped and are being held hostage on the ward.
It's important to note a clinical nuance here regarding the geriatric population, though. While florid visual hallucinations are common, older adults often present with more subtle somatic neurological features.
That's right. The onset of delirium in an 85-year-old might be heralded by sudden urinary incontinence, the emergence of a new resting tremor, acute gait instability leading to a fall, or sudden expressive dysphagia where they cannot articulate their thoughts.
The brain's failure manifests through both cognitive and physical circuitry.
Exactly. And context heavily dictates the presentation, which is why the textbook details delirium in special settings. Let's analyze ICU delirium first, as it really represents the highest concentration of risk.
The intensive care unit is essentially an assembly line for cognitive insult.
It is. The ICU environment perfectly amalgamates extreme baseline vulnerability with relentless precipitating factors. The patients are suffering from severe life-threatening pathologies, multi-organ failure, profound hemodynamic instability, and overwhelming systemic inflammation from sepsis.
And inflammatory cytokines like interleukin-6 and tumor necrosis factor alpha are known to cross the blood-brain barrier, triggering massive neuroinflammation and directly suppressing neuronal function.
In addition to the endogenous inflammation, we introduce exogenous trauma. We place them on mechanical ventilation. The environment is completely devoid of natural light cycles. Alarms are incessantly blaring, resulting in absolute sleep deprivation.
But the most significant iatrogenic insult is our use of sedation, isn't it?
Absolutely. Deep continuous sedation is a profound risk factor. Medications like propofol, and particularly opioids like morphine, accumulate in the adipose tissue and the central nervous system.
And morphine has active metabolites that can linger for days, especially if the patient's renal function is compromised.
This is exactly why modern critical care has pivoted towards the ABCDE bundle, a protocol specifically designed to mitigate these iatrogenic insults.
Oh, right, the ABCDE bundle. Can you break that down?
Sure. It mandates continuous assessment of pain, daily trials of spontaneous awakening and breathing to reduce ventilator time, careful choice of light rather than deep sedation, rigorous delirium monitoring, and early mobility.
Early mobility is huge. Getting an intubated patient out of bed and bearing weight sends massive proprioceptive signals to the brain, which strongly aids in reorientation.
It really does. Now, moving from the ICU to the surgical wards, post-operative delirium is another massive clinical challenge.
Yeah, and it typically manifests within the first 48 to 72 hours following a procedure. Orthopedic surgeries, particularly hip replacements in the elderly, carry an incidence rate ranging from 15 to an astonishing 60%.
And the risk factors in a hip replacement perfectly illustrate that multifactorial model we talked about.
Well, full cup.
Right. You have an elderly patient, often with pre-existing vascular dementia or cognitive decline. They sustain a painful fracture, triggering a systemic stress response. They're subjected to general anesthesia, systemic inflammation from the surgical tissue trauma, blood loss causing microcerebral hypoperfusion, and the heavy administration of postoperative opioids.
It is a massive pour of water into an already full cup.
Exactly. Similarly, cardiac surgeries, such as a coronary artery bypass graft or CABG, carry immense risk.
Why is that?
Well, during cardiopulmonary bypass, the brain may be subjected to microemboli, altered perfusion pressures, and significant systemic inflammation. The duration the patient remains intubated post-surgery, alongside the frequent development of postoperative atrial fibrillation, dramatically increases the likelihood of a neurocognitive crash.
Wow. We also have to discuss the deeply profound presentation of delirium at the end of life, frequently termed terminal restlessness.
Yes, this occurs in palliative care settings and can affect up to 88% of patients with advanced terminal illnesses like metastatic cancer.
And terminal restlessness is extraordinarily distressing for families to witness. Their loved one, in their final days, becomes severely agitated, plucking at their bed sheets, hallucinating, and seemingly in absolute anguish.
The etiology there is multifactorial, driven by progressive multi-organ failure, hypoxia, the accumulation of toxic metabolites due to renal shutdown, and the high doses of opioids required to manage terminal pain.
And the clinical approach here shifts significantly, doesn't it?
It does. While clinicians will attempt to identify easily reversible causes, perhaps the patient is in acute urinary retention or requires a hydration adjustment, many cases in the final hours are irreversible.
So what do you do?
In these instances, the ethical and clinical mandate is palliation. We utilize palliative sedation, often with continuous infusions of midazolam or levomipramazine, not to treat the delirium, but to ease the patient's profound distress and allow for a peaceful death.
To round out the clinical manifestations, we should probably acknowledge that this is not exclusively a disease of the elderly. Pediatric delirium is a highly recognized entity.
Yes, though its presentation differs due to the developing nature of the child's brain.
Right. Children who become delirious, perhaps due to a severe viral encephalitis or high fever, rarely present with the classic systematized delusions or complex memory impairments seen in adults, do they?
No. Instead, the failure of their nascent cognitive networks manifests as extreme affective lability. Their emotions swing violently and unpredictably.
They exhibit severe irritability, inconsolable crying, and profound disruptions of their sleep-wake cycle.
And importantly, they may fail to recognize their own parents, which is a key diagnostic indicator in a pediatric setting. The underlying mechanism, the failure of attention and cerebral metabolism, is identical, but the symptomatic expression is filtered through an immature nervous system.
Okay, so given that delirium is such a chameleon, it can mimic a tantrum in a toddler, a deep depression in a geriatric patient, or a psychotic break in an adult. How do clinicians actually solve the mystery and treat the patient?
This leads us into the critical domain of integration in clinical reasoning. The physician must construct a precise differential diagnosis, systematically spotting the imposter by comparing delirium against its clinical lookalikes.
And the most common and arguably the most difficult differential is distinguishing dementia from delirium.
Yes. The primary distinguishing axis is temporal. Dementia is an insidious, progressive neurodegenerative process. The decline occurs over months or years. Crucially, in a patient with uncomplicated dementia, their level of alertness and consciousness remains entirely intact until the final stages of the disease.
They may have severe short-term memory deficits, but they are fully awake, alert, and engaged with their environment.
Delirium, conversely, is acute. The derailment happens over hours to days, and the defining feature is that alertness is fundamentally impaired. The consciousness is clouded.
But the problem arises when these two conditions overlap, creating delirium superimposed on dementia, or DSD.
DSD is the ultimate diagnostic challenge. You have a patient whose baseline is already impaired.
So how do you crack it?
The key to unlocking this diagnosis is identifying the sharp inflection point. You must look for a sudden, precipitous drop in their cognitive function compared to their established baseline from just a few days prior, accompanied by the characteristic fluctuation in their level of arousal.
Another critical differential is depression versus hypoactive delirium. As we discussed, the hypoactive patient is lethargic, socially withdrawn, and exhibits limited speech. This perfectly mimics a major depressive episode with psychomotor retardation.
Right, and the differentiating factor relies on assessing the integrity of the patient's awareness. A patient suffering from severe depression has an intact, stable level of consciousness. They are painfully aware of their surroundings and their internal despair. They simply lack the neurochemical motivation to engage.
The hypoactive delirious patient, however, has a clouded sensorium. They are disoriented, they cannot sustain attention to your questions, and their level of arousal fluctuates throughout the day.
Finally, we must differentiate functional psychosis like an acute exacerbation of schizophrenia or bipolar mania from hyperactive delirium. If a patient is brought into A&E agitated and shouting about demons, how do you determine the etiology?
Phenomenology provides the clues here, right?
Yes, exactly. Psychotic hallucinations in primary psychiatric disorders are predominantly auditory patients, hear voices narrating their actions or commanding them. Their delusions, while bizarre, are often highly systematized, consistent, and complex.
Delirium, by contrast, features predominantly visual or tactile hallucinations. The delusions are fragmented, poorly formed, and fleeting.
Furthermore, a patient with schizophrenia will have a normal, awake EEG reading. If you suspect delirium, an EEG would reveal the telltale diffuse, slow-wave activity, confirming the metabolic failure.
Understanding these differentials is paramount, but the textbook stresses a very humbling reality. Despite these clear clinical guidelines, up to 2/3 of cases are still missed.
Yes.
When you analyze the root cause of these diagnostic failures, it rarely comes down to missing a subtle finding on an MRI. What is the single biggest reason clinicians fail to diagnose delirium?
It is the failure to obtain a collateral history. The diagnosis hinges entirely on establishing an acute change from baseline. You just cannot determine if a state is acute if you do not know what normal looks like for that specific individual.
If an 82-year-old patient is admitted alone from a nursing home and they are confused, mumbling, and disoriented, you have absolutely no point of reference. I mean, have they been in this exact cognitive state for 3 years due to advanced Alzheimer's disease? Or were they balancing their checkbook and playing bridge yesterday afternoon?
And exactly that reasoning dictates a fundamental rule in geriatrics and emergency medicine. If an older patient presents with confusion and you cannot obtain a collateral history from a caregiver, family member, or nursing facility to establish their baseline, you must assume they are delirious until proven otherwise.
You must assume it is a medical emergency.
Absolutely. To systematize this assessment, clinicians rely on validated tools, the most prominent being the confusion assessment method, or the CAM.
The CAM. It's a brilliant, highly sensitive bedside tool that takes mere minutes to administer. It requires the presence of specific features, doesn't it?
The CAM algorithm is straightforward but rigorous. Feature 1 is an acute onset and fluctuating course. You ascertain this from the collateral history.
Okay.
And Feature 2.
Feature 2 is inattention, which you can test directly by asking the patient to spell a word backwards or recite the months of the year in reverse. A delirious patient will invariably lose their place. To meet the criteria for delirium, the patient must have both Feature 1 and Feature 2.
That establishes the acute attentional failure. Then what?
Then they must exhibit either Feature 3, which is disorganized thinking manifesting as rambling, irrelevant conversation, or an illogical flow of ideas, or Feature 4, which is an altered level of consciousness.
Meaning any state other than alert.
Exactly. If they are hypervigilant, lethargic, stuporous, or unarousable, they meet Feature 4. If they have 1 and 2, plus either 3 or 4, the diagnosis of delirium is confirmed. Once the diagnosis is confirmed, the investigative phase begins. You must find the precipitating insult. You have to find the drop that caused the cup to overflow. Now, in modern medicine, there is a tremendous temptation to immediately order high-tech, expensive diagnostics. Why not just send every confused patient for a full-body MRI or a CT scan of the brain?
Because it represents incredibly poor clinical reasoning.
Yeah.
We have to reiterate, delirium is a disorder of function, not of macroscopic structure. Neuroimaging, such as a CT or MRI of the head, has an exceptionally low diagnostic yield in the routine workup of delirium.
The scan will merely reveal age-related cortical atrophy or chronic microvascular ischemic changes, which do not explain the acute crisis.
Exactly.
So when is a brain scan actually justified?
You reserve neuroimaging for cases where there are new focal neurological deficits. For instance, if the patient has sudden asymmetrical weakness, a facial droop, or unilateral pupillary changes. Alternatively, imaging is mandatory if there's a recent history of head trauma or falls, where you must urgently rule out a subdural hemorrhage.
But in the absence of focal signs or trauma, routine scanning is a waste of critical time.
It is. Instead, the pathology and laboratory evaluation must be targeted, focusing on the common systemic insults that disrupt brain metabolism. You order a chest x-ray to look for lobar pneumonia.
You run basic blood chemistries, scrutinizing the sodium, calcium, and blood urea nitrogen to detect renal failure or severe dehydration.
You use pulse oximetry to ensure the brain is not simply hypoxic. However, in this pursuit of a cause, there is a massive diagnostic trap that frequently ensnares clinicians, particularly in geriatric and nursing home populations.
Oh, the UTI trap. This is a critical clinical nuance.
It really is. As human beings age, changes in the bladder architecture and immune senescence mean that it is incredibly common for older adults to have bacteria colonizing their urinary tract without causing any tissue invasion or systemic infection. This is known as asymptomatic bacteriuria.
This creates a treacherous cognitive bias for the physician, doesn't it? An elderly patient becomes suddenly delirious. The junior doctor, eager to find a cause, orders a urinalysis. The lab report returns showing bacteria and perhaps a few white blood cells. The doctor triumphantly declares it is a urinary tract infection, prescribes a course of broad-spectrum antibiotics, and basically ceases all further investigation.
That premature closure is highly dangerous. The bacteria in the urine may be entirely incidental, a chronic baseline state for that patient. Meanwhile, the true precipitating insult, a silent myocardial infarction, a pulmonary embolism, or an acute toxicity from digoxin, goes completely unrecognized while the patient's brain continues to fail.
The clinician must balance antibiotic stewardship with physiological reality. Diagnosing a true UTI requires systemic signs of infection, right?
Right. Pyrexia, dysuria, suprapubic tenderness, or a significantly elevated neutrophil count in the serum.
However, we must introduce a caveat to that rule. We must balance that caution against the knowledge that older, frail, or immunocompromised patients exhibit blunted immunological responses. They may be entirely incapable of mounting a fever or producing a leukocytosis.
That's very true. In these fragile patients, a sudden, profound alteration in mental status might be the sole, isolated, presenting symptom of overwhelming neurosepsis. It requires the clinician to act as a true investigator, weighing the entire clinical picture rather than relying on a single lab value.
Assuming the clinician successfully identifies and begins treating the underlying cause, be it sepsis, hypoxia, or drug toxicity, we must turn our attention to the direct management of the delirious state itself.
And the overarching golden rule of delirium management is that prevention is paramount. Preventative strategies exponentially outperform any pharmacological treatment we possess.
The textbook highlights several landmark initiatives, notably the Hospital Elder Life Program, or HELP, and the Yale Delirium Prevention Trial. These are not cutting-edge pharmacological trials. They are massive, systematized, non-pharmacologic interventions, and their protocols are shockingly simple.
They are simple, but they are grounded in profound neurobiology. These programs focus on preserving the patient's cognitive reserve and providing the brain with the sensory data it requires to maintain reality.
What do these interventions actually entail?
Well, they mandate the placement of large, readable clocks and clear calendars in every patient room to continuously reinforce orientation. They ensure the patient's room has a window with natural sunlight to preserve the circadian rhythm and prevent sundowning.
They enforce early, aggressive mobility protocols, getting patients out of bed and walking, rather than leaving them tethered to monitors. They meticulously monitor fluid intake to prevent dehydration.
And perhaps most crucially of all, they ensure that the patient's sensory deficits are immediately corrected. They give the patients back their spectacles and their hearing aids.
Which makes sense. Consider the iatrogenic environment we discussed earlier. If you take an 85-year-old with macular degeneration and presbycusis, confiscate their glasses and hearing aids, place them in a windowless room illuminated by fluorescent lights 24 hours a day, tether their arms with intravenous lines, and wake them every 2 hours for observations.
It is a physiological certainty that they will become delirious.
Yeah.
You have artificially engineered a state of profound sensory deprivation.
Restoring those senses, giving the brain its anchors back, is the absolute first line of both prevention and treatment.
Exactly.
This heavy emphasis on non-pharmacologic management brings us to a stark, often surprising reality about the pharmacology of delirium. When we face this severe cognitive crisis, surely modern psychiatry has developed a specific pharmacological cure.
The sobering truth is that there are currently 0 medications approved by the FDA or the MHRA specifically for the treatment of delirium. None. Every single pharmacologic intervention we utilize is entirely off-label, and every agent carries immense physiological risk.
Wait, really? None. So we only cross the threshold into pharmacological management when the patient's behavior poses an imminent, severe safety risk.
Yes, we intervene with drugs only if a hyperactive patient is attempting to extubate themselves, ripping out arterial lines, or actively assaulting the nursing staff.
In those extreme emergencies, what agents are deployed?
Antipsychotics are the mainstay for chemical restraint in these scenarios. High-potency, first-generation antipsychotics, particularly low-dose haloperidol, are frequently administered off-label.
Why haloperidol?
Haloperidol is often favored because, relative to other agents, it has minimal anticholinergic properties, meaning it won't further degrade the cholinergic pathways we discussed earlier. Furthermore, it rarely causes respiratory depression or significant hypotension.
However, haloperidol is a potent dopamine antagonist, and it is far from benign. The side effect profile is severe. It carries a high risk of extrapyramidal side effects, or EPSE.
Yes, because you are blocking dopamine receptors in the basal ganglia, you can induce severe muscle spasms, acute dystonias, or profound internal restlessness known as akathisia.
An even more critical danger arises if haloperidol is administered intravenously. For haloperidol carries a significant risk of prolonging the QTC interval on the heart's electrical cycle.
And that prolongation can trigger a fatal ventricular arrhythmia known as torsades de pointe. Therefore, continuous electrocardiogram, or ECG, monitoring is absolutely mandatory when using the intravenous route.
The textbook also notes the increasing use of second-generation or atypical antipsychotics, such as risperidone, quetiapine, or olanzapine. They have a lower risk of extrapyramidal symptoms, which seems advantageous.
They do show clinical utility, but we must immediately contextualize this with the patient's baseline vulnerability. Remember that pre-existing dementia is the primary risk factor for delirium. Regulatory agencies worldwide have issued stringent black box warnings regarding the use of atypical antipsychotics in elderly patients with dementia, as they are associated with an increased risk of stroke and all-cause mortality.
The clinician is truly walking a perilous tightrope between managing acute agitation and risking fatal complications.
They are, and this delicate balance is perfectly illustrated by the benzodiazepine paradox.
The benzodiazepine paradox. Historically, in the mid-20th century, if a patient became highly agitated and delirious, the standard reflex was to administer a benzodiazepine like diazepam, or lorazepam, to sedate them.
Which we now understand is the equivalent of trying to extinguish a fire by pouring petrol on it.
Wow.
Current robust evidence demonstrates unequivocally that administering benzodiazepines to a standard delirious patient actually increases the severity of the delirium and significantly prolongs its duration. While the drug may successfully suppress the physical agitation, it achieves this by further deranging the already compromised neurochemical networks. It deepens the cognitive failure.
However, there is one absolutely critical exception to this rule. A specific scenario where a benzodiazepine is not only safe, but is the mandatory, life-saving, first-line treatment.
Yes, and that exception is when the delirium is precipitated specifically by substance withdrawal.
Like alcohol withdrawal.
Exactly. If the underlying etiology is severe alcohol withdrawal, the condition known as delirium tremens, or withdrawal from other sedative hypnotic agents like barbiturates or benzodiazepines themselves, the neurobiology is fundamentally different.
In withdrawal, the brain has become structurally dependent on the depressant. When it is removed, the central nervous system goes into massive, unregulated hyperexcitability.
In these specific cases, you must administer a benzodiazepine. You're replacing the missing depressant to suppress the hyperexcitability and prevent fetal status epilepticus, gradually tapering the dose down to safety.
Beyond antipsychotics and benzodiazepines, the textbook details specific pharmacological antidotes or reversal agents. If the delirium is conclusively driven by a massive anticholinergic intoxication, for instance, an intentional overdose of tricyclic antidepressants or first-generation antihistamines, the specific reversal agent is phosphatidylstigmine.
Yes, phosphatidylstigmine works by inhibiting the enzyme acetylcholinesterase in the synaptic cleft. This prevents the breakdown of acetylcholine, allowing its levels to rise and overcome the receptor blockade, thereby restoring the critical cholinergic pathways.
And if the delirium is secondary to profound opioid toxicity, the intervention is naloxone, a competitive antagonist that rapidly displaces the opioid molecules from the mu receptors.
And for isolated benzodiazepine overdose, the specific antagonist is flumazenil. However, flumazenil comes with a severe clinical warning that every physician must heed.
The danger of mixed ingestions.
Precisely. In A&E, patients often present after ingesting a combination of substances, frequently a mix of benzodiazepines and tricyclic antidepressants.
Right, and if a patient has a tricyclic antidepressant in their system, their seizure threshold is already dangerously lowered.
Exactly. If you rapidly administer flumazenil to reverse the benzodiazepine, you instantly strip away the seizure-suppressing effect of the benzo. This sudden reversal can precipitate intractable, fatal status epilepticus, and severe cardiac dysrhythmias. Flumazenil should rarely, if ever, be used empirically in an undifferentiated coma or mixed overdose.
Finally, we must ask, what if all these interventions fail? What if you have a patient in a refractory, severe, hyperactive delirium who is entirely unresponsive to antipsychotics and whose extreme agitation is actively threatening their life through sheer cardiovascular exhaustion?
The absolute last resort in the clinical arsenal is electroconvulsive therapy, or ECT.
ECT for delirium.
Yes. ECT can rapidly reset the brain's electrical activity and break the cycle of severe, life-threatening agitation. However, its use is exceedingly rare and requires immense clinical caution because ECT induces a massive generalized seizure, and the post-ictal state itself can temporarily induce or exacerbate delirium. It is a calculated risk taken only when all other options have been exhausted.
Okay, so once the clinical team navigates the acute crisis, the underlying cause is treated, and the patient's sensorium clears, they are discharged from the hospital. Is the story over?
We have to discuss the prognosis because delirium casts an incredibly long shadow over the patient's future.
It does. For decades, the medical consensus viewed delirium as a purely transient, completely reversible state. The analogy held. The power goes out, the engineers fix the generator, the lights come back on, and the city resumes normal operations with no lasting consequences.
But large-scale longitudinal data has completely shattered that assumption. The recovery is rarely swift or complete. No, it's not. While the acute florid symptoms generally resolve within 5 to 7 days following the treatment of the underlying cause, a significant percentage of patients experience a prolonged tail of cognitive impairment.
The data shows that up to 15% of older adults who experience an episode of delirium remain symptomatic, with persistent attentional and executive deficits a full 6 months after discharge.
And the most alarming prognostic data, however, concerns mortality and long-term cognitive trajectory. Experiencing a severe episode of delirium independently doubles a patient's mortality risk for years following the event, even after controlling for the severity of their underlying physical illness.
It doubles the risk of death. And for those patients who arrived with baseline vulnerabilities, those whose cups were already full, the consequences are devastating.
If a patient with pre-existing mild cognitive impairment or early-stage dementia suffers an episode of delirium, it drastically alters the trajectory of their neurodegeneration. It acts as a massive accelerant.
Following the delirium, their cognitive decline steepens sharply. They lose functional independence faster, require institutionalized care sooner, and reach the end stages of dementia significantly earlier than they would have otherwise.
This profound, long-term impact on the brain's architecture brings us to a conceptual crossroads. We have covered an immense amount of ground today, from ancient history to modern neurochemistry. Let's distill the key takeaways from Chapter 10.2 so that our listeners can firmly lock this mental model into their clinical reasoning.
I will outline the core principles first. Delirium is fundamentally a medical emergency of brain function and metabolism, not a process of structural decay. It is the city's power grid failing, a crisis of neurochemical signaling and energy failure directly verified by the diffuse slow-wave activity seen on an EEG.
Second, attention is the central pillar that falls first. Because the reticular activating system fails to filter information, the patient cannot attend to stimuli. Consequently, memory registration, executive function, and perception become entirely chaotic.
Third, hypoactive delirium is the most common presentation in the elderly. It is silent, easily misattributed to depression or normal fatigue, and therefore deadly if missed. You must differentiate incomplete pathological arousal from normal sleep.
Fourth, the collateral history from a caregiver is the single most vital diagnostic tool you possess. It is the only reliable method to establish the acute drop from the patient's baseline, which is required by the confusion assessment method criteria.
And finally, prevention heavily outweighs pharmacological treatment. Restoring sensory anchors with glasses and hearing aids, maintaining circadian rhythms, and avoiding iatrogenic polypharmacy are your best interventions. There are no FDA or MHRA-approved medications for delirium, and the off-label use of antipsychotics or benzodiazepines carries immense physiological risk.
To ensure these concepts are deeply integrated into your clinical reasoning, we are now going to transition into our learning reinforcement module.
Yes. This is a rapid-fire quiz designed to test your mental models. I will present a clinical scenario or conceptual question based on everything we have just discussed. I will ask the expert, but you, the listener, I want you to actively participate. Mentally lock in your answer during the pause before the expert provides the full physiological explanation. Are you ready?
I am ready. Let's do it.
Question 1 focuses on mechanisms. In the mid-20th century, George Engel and John Romano utilized electroencephalography to demonstrate the underlying physiological mechanism of delirium. What specific EEG finding best correlates with the profound cognitive and attentional deficits seen in this syndrome, and what does it represent biologically? Take a second.
Right, so the hallmark finding is diffuse slow-wave activity, typically in the theta or delta range, often accompanied by low-voltage background activity. Biologically, this represents a global reduction in cerebral metabolic activity. The neurons lack the energy to maintain rapid, asynchronous firing, reflecting a profound energy crisis in the brain.
Spot on. Question 2 focuses on clinical reasoning. You are evaluating a 78-year-old patient on a general medical ward who is socially withdrawn, speaks minimally, and displays profound psychomotor apathy. The primary surgical team suspects a major depressive episode. What single clinical feature is most critical in differentiating hypoactive delirium from depression in this specific patient? Take a moment.
Yeah, the critical differentiating feature is an acute change or fluctuation in the level of consciousness and awareness. A patient with severe depression generally maintains an intact, stable, and clear level of consciousness. A patient with hypoactive delirium exhibits a clouded sensorium, profound inattention, and incomplete arousal when stimulated.
Exactly. Question 3 focuses on concepts. When considering the multifactorial model of delirium, balancing baseline vulnerabilities against precipitating insults, which predisposing factor confers the absolute highest vulnerability for the development of delirium in an older adult? Lock it in.
Pre-existing dementia or significant underlying cognitive impairment. This represents a severely diminished cognitive reserve, meaning the brain's homeostatic buffer is nearly depleted, requiring only a minimal physiological insult to trigger a massive functional collapse.
Brilliant. Question 4 focuses on pharmacology and mechanisms. A patient presents to A&E with acute hyperactive delirium, widely dilated pupils, hot, dry skin, severe tachycardia, and urinary retention following an accidental overdose of over-the-counter sleep aids. If a pharmacological reversal agent is deemed absolutely necessary to prevent life-threatening complications, which neurochemical mechanism is targeted and what is the preferred agent? Take a second.
Right. Well, the clinical presentation is the classic toxidrome of anticholinergic poisoning. The pharmacological target is to inhibit the enzyme acetylcholinesterase in the synaptic cleft, thereby raising acetylcholine levels to overcome the receptor blockade. The preferred reversal agent is physostigmine.
Spot on. Question 5 focuses on integration. In the intensive care unit, a patient develops severe hyperactive combative delirium. The critical care team considers administering a continuous infusion of a benzodiazepine to sedate the patient and protect the airway. Under what specific etiological circumstances is a benzodiazepine considered a first-line, appropriate, and life-saving treatment for delirium? Lock it in.
Benzodiazepines are only indicated as a first-line treatment when the delirium is definitively caused by substance withdrawal syndromes. Specifically, this applies to severe alcohol withdrawal, delirium tremens, or withdrawal from sedative hypnotic agents like barbiturates or other benzodiazepines, where the drug is required to suppress massive, unregulated central nervous system hyperexcitability.
Exactly. And question 6, our final coin, focuses on clinical reasoning. A junior clinician is assessing an 82-year-old nursing home resident who presents with a sudden onset of profound confusion and visual hallucinations. The clinician decides to order a full, comprehensive panel of diagnostic tests. According to current psychiatric and medical guidelines, when is a lumbar puncture, a cerebrospinal fluid examination, routinely indicated for a delirious patient? Take a moment.
A lumbar puncture is not routinely indicated in the standard workup for delirium. It should be reserved specifically and exclusively for patients presenting with delirium accompanied by fever or meningeal signs, in whom an acute central nervous system infection, such as bacterial meningitis or viral encephalitis, is actively and highly suspected.
Outstanding.
For those of you who wish to push your clinical reasoning even further and master the subtleties of this topic, I highly direct you to read the full text of Chapter 10.2 in Kaplan and Sadok's comprehensive textbook of psychiatry. The historical nuances, the detailed breakdowns of the neurochemical pathways, and the depth of the pharmacological warnings provided in the text are absolutely essential reading for any clinician.
As we conclude this deep dive, I want to leave you with one final provocative thought. We noted during our discussion of prognosis that families often report their loved ones never fully return to baseline after a severe episode of delirium. We explored the alarming data showing that an episode accelerates the trajectory of dementia and significantly increases long-term mortality.
Yeah, that data is sobering.
It is. This clinical reality forces us to ask a profound, unsettling question about the brain's resilience. Is delirium truly just a temporary power outage of function, as our opening metaphor suggests? Or does the intense physiological stress, the profound energy crisis, and the neurochemical toxicity of the delirious state actively destroy the physical infrastructure of the brain itself? If a supposedly functional transient syndrome causes permanent structural damage, it challenges the very boundary we draw in medicine between functional illnesses and structural neurodegenerative diseases. It is a question at the very frontier of psychiatric research and certainly something for you to mull over. Here are the details of this episode.
Delirium. Byline. Medlock Holmes enters a city whose citizens have suddenly become confused. Streets that once made sense now seem unfamiliar. Familiar faces become strangers. Day turns into night without warning. Yet Holmes soon discovers that the city itself is not damaged. Instead, its power supply has become unstable.